right, here we are to evaluate a knee. I'm going to show you the way I do it. There's a few different ways to do it, but this is, like I said, I do most of it in the surgical chair. I'm going to have the patient scoot out just a little teeny bit, and I'm going to use this knee as my table. That gives me some availability to maneuver and get to the advantage of isolating what I need to isolate. I'm going to grab down here as if it were a pump handle, and that helps me here. Use this hand to palpate the joint. I know I've got big hands, but you're going to be evaluating your daughter. Even if you're on a big knee, you can do one side at a time. But you're going to come down here. It's just the femoral tibial joints. You can feel it here, feel it here. This allows you to palpate for tenderness. If you have an EX tibia somewhere along the line here, you're going to find tenderness right there. If you're going to have more of a femur involvement or femoral involvement, you're going to find it in here. Find the joint. You might have to move it around to find the joint, and you'll be able to isolate the tenderness. The tenderness at that joint will actually be in the meniscus, so you have to kind of feel for that. You can have a broad amount of tenderness out here, or even ask the patient to please point to where you find your tenderness, and oftentimes they're pointing up in here, kind of just medial to the patella, and that's more of a bursa tear or bursa irritation. More of a medial collateral ligament, you'll have a broad amount of tenderness all through here. The meniscus tenderness will be a very small little line, I mean just about your pinky size right in there, and you'll be able to elicit that as you put your finger on that. Now to motion palpate this, stick your thumb in the lateral part, stick your fingers on the top part here. Now what you're going to do is you're going to push down here on the femur, and you're going to isolate that. You're going to stabilize the femur. You're going to move the lower leg like this. Okay, you don't want to do this because you're not going to have any stability. You want to keep this totally stable. You might have to encourage the patient to just let up, lighten up, so they're nice and loose for you. Some of them want to hold it so rigid on you. So find your joint, get in, even if you have to do it one at a time, get inside the meniscus, the menisci right here, push down, and then just isolate, okay? Gail here has pretty good motion on both. It should give you a little slide this way and a little slide this way. When you have an EX tibia, it's going to kind of jam a little bit. There's not going to be much there at all, okay? Here's a little bit. She's got pretty good movement, maybe just a wee little bit of jam on this EX tibia, but you should be able to isolate it pretty good. And to get a little rotation, just rotate. You're going to rotate. So if I'm finding a little jam on the EX side here under my thumb, rotate it back. Does it go freely this way or freely this way? If it's wherever you're more free, that's probably the angle that's already there. If it's a PEX tibia, it's going to be out and then already kind of hanging back, so it's going to really want to rotate pretty far that way. If it's an AEX tibia, it'll already rotate that far, it won't want to rotate back. So that's the basics right there, okay? To adjust this, you're going to be in the same position for the EX tibia part. I'll show you those adjustments right now. And that is simply to find your joint, and to adjust any EX tibia, you need to contact with your piezoform, but you also need to be on the meniscus right here. So you're not going to be way down on the tibia. You're going to be just off the femur. So you grab a little of the meniscus along with the tibia, okay? So you come down off of this. It probably is going to be pretty tender if this is what's going on. And just you pull down a little with your opposite thumb, roll in your piezoform, grab underneath here, and not total locked out, but not a big bend, just a little past that. You're going to kind of lean back to kind of straighten out, and you're going to drive through. I'm driving through with my contact hand. Boom. Okay, just it's a kind of a load firmly, just a little bit at there. And sometimes when it releases, it'll go clunk, really big like that. So hers is fine, so there's not going to be much release. If you have a rotational component that you found out, well, if it's PEX, well, I'm going to rotate it around and do that. If it's AEX, I might rotate in this way and come in this way. So I hope that makes good sense. That's for the ilium. That's for the tibia alignment this way here. You can have a straight posterior tibia that subluxates just pretty much straight posterior. There's not a great analysis for that. I mean, you can palpate back here. It may be tender. That's that can be a good analysis for this, but also you can have tenderness back there for a number of reasons. You can have swollen lymph nodes. You can have just everything swollen. There's so much soft tissue back there, so it's hard. I use the check it and adjust it method. If it moves, it probably needed it. If it didn't need it, then it's not going to move too much. It's pretty safe to do. And again, I do this in this position right here. I take it like this. All right, I've done my thing. All right, I just kind of think it's posterior. Let's check it. I just come in right here. My contact is going to be right here and here. Find a little tension spot and take out the slack. And I'm just going to go boop. I'm going to just pop back this way. It's going to take a little strength through your bicep, but you're going to kind of lean in with your body a little bit. Tension, 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 and like this. Like that. Okay, it's pretty firm, but it's pretty quick, and amazingly, you'll get a lot of good audible like that if it needs to release, and it'll do pretty good that way. That's the way I do it. Probably over 90% of the Gonstead doctors, if they're going to adjust a straight posterior tibia, they're going to be putting the patient prone on the high-low, getting behind them at the foot of the table, bending the leg up, putting it over your shoulder, and reaching in this. You probably have seen that before. And then you just kind of isolate where the fixation is, and then you just pull back on you like that to correct it like that. That works. I've done that before. I just actually find this easier. When I'm doing that, kind of a big tall guy with a stiff back, it's a little hard on my back to stay down that low for that long. So that's how you manage the EX tibia component. If you're going to do a femur component, one more thing here. You mentioned that Emma has a lot of soreness in here, and if you're correcting the EX component with that amount of soreness, I can understand how just even taking the slack out is going to light her up here. That's pretty normal. To get around that, have an assistant stay over here, and they put their hand, their left hand right up in here, and have them put their hand right in here up against the femur, okay? They don't have to be down on the meniscus, but really close to the joint. Lean their hand in, and maybe their other hand over it, or even up here in the thigh, just so that they're holding like that against your pressure. They're not trying to over push, they're not trying to thrust at the same time, they're just trying to anchor you so that you can freely work on your tibia without any extra slack, without any extra give. It's nice and secure, nice and stable, and boom, just like that. I know there's alternative moves to this. Contact me if you want to know any alternative moves, but I find this pretty quick and easy this way. If you do a femur, I'll just switch legs, just the camera angle here. Same type thing. You've already determined it. I would have sat on this side to determine if it's a femur. I'm going to come over here and get in on the femur, not down here because I'd be all over the tibia. I'm going to actually use my thenar contact, and again, I'm going to come off of the femur onto the meniscus, and same type thing. Not straight out like this, not too much bend, just a little off straight. And I'm going to lean in, squeeze in, and boom, with this left hand here, right there. Oh, that was a freebie. So there you go. So any other questions on that, just contact me. I think I've covered just about everything, and that should at least get you in the ballpark as far as analysis with static palpation for edema along the meniscus on the lateral and the medial, and motion palpation anchor down. It's going to be a pressure squeeze down while you move it this way and rotate around. You'll be able to assess what's going on pretty well, and also the correction of it however you need to with that too, making sure you contact the meniscus as well on these EX tibias. Have somebody stabilize if she's too sore in here as you get ready to thrust. She should do pretty good with that. If you need anything else on this, just let me know. So I think that'll wrap it up. Thanks.